Okay, guys, we're going to go ahead and get started. Just, just to open up with you, we originally had three presenters, Kelly DeFrancisco, and I'm so sorry that Kelly couldn't make it today because Kelly represents Aetna, the Medicaid business unit, and she oversees their Medicaid program in 16 states, of which several of them are in the matrix group. Because so many of us are very heavily dependent on Medicaid, I thought that would be an interesting discussion. I'm sorry that we won't be able to have that today. She had a family crisis, and so she's having to deal with that. But we're still good. We'll have it, and I think you guys actually said you can kind of cross paths a little bit, so I think it'll be fine. We have plenty of time in today's session, especially with not having Kelly's presentation. So please feel free in the course of the conversation, if you have a question or you want to bring something up, please raise your hand. I think we'll have plenty of time for interaction back and forth. Nobody has conflict of interest. And this will be the path that we follow in the program today. We actually have 9 themes that we're going to emphasize. But again, I think we have plenty of time today that we can take this anywhere that you guys would want to if those 9 themes don't necessarily touch on exactly what you're most interested in. I just wanted to start for a moment. I've been doing telehealth for 30 years, and again, when I started in the mid-90s, the first priority for us was to figure out how were we going to get the payers to pay for a telehealth encounter, because honestly, if we didn't figure that out, I didn't have a job. We could not continue to do telehealth, and so much has happened over 30 years. But the first 5 years in Kentucky, my effort, because honestly, I'd never done legislative advocacy before, and the idea of going to Washington and lobbying for CMS and working with our federal legislators was so far off the table for me that I said, well, we'll start within the state. And we got incredibly lucky, and I think if any of you heard the session yesterday that Joe McMenamin moderated for us, if you look back on any career, but I certainly can in mine, luck played a remarkable point in several places, and especially that led to our ability to move the needle with reimbursement. And within our state, I got incredibly lucky to find one legislator that just said that this is important to me. I want to get behind this. And literally with one person driving the bus in the mid-1990s, we were able to be, and I think we were the first state in the country to have state legislated mandated Medicaid and commercial health plan reimbursement for telehealth. We had parity legislation that said whatever you get for a traditional in-person encounter, you get that for telehealth. And so that part of the work was done, and then we were able to focus on working on federal legislation. So we were really honored to have Drs. Wheelock and Bolger representing the payers speak to us today. We, rarely get the opportunity to have this kind of back and forth unless we approach the payer community with an ask. And again, I remember 10, 15, 20 years ago, that sometimes became adversarial. And 20 or 30 years ago, they would look at us and go, you want to do what? You want to see a patient through a video conference? And it was a crazy idea back then. Fortunately, things have become much better. And so these meetings that we have with the payer community, and if you guys get into any of that, over the last few years become much more collaborative. We're both looking for the same thing, to improve the outcomes of patients, to keep cost in check. All of those things are common, I think, to both us and to the payer community. And certainly COVID crisis exponentially picked that up to where that became the unifying event that brought the payer and provider community together. So as we continue to put the COVID PHE behind us, many of us worry about what's going to happen from a legal and regulatory perspective. Are the rules at the end of 2025 going to revert back to pre-COVID levels? And so I want to thank you guys for taking time to come and speak to us today. I think it means a lot to this audience. Right. So, Dr. Bolger, let's just do introductions. If you would, introduce yourself, but also kind of tell us, how did you get to this place where not only are you a provider, but you're also a payer?
Sure, thank you. And not how I got here this morning, right? Because I just drove right straight across Route 80 to.
Okay.
I live like 3 miles from Route 80, so I went to Route 80, came across Route 80. Anyway, and did everybody get their taxes done? I got mine done 6 o'clock last night. I had a Sunday afternoon. I had a televisit with someone from TurboTax to make sure I was. I did anyway. So I'm a physician. I'm a general internist. I've been at Geisinger my whole post-residency career. So I spent the first 17 years on the clinical side, and then some would say went to the dark side. You said the back and forth with health plans. I kind of go back and forth in my own head many times during the day. But I became the chief medical officer of our health plan in 2015. And along the way, I did a lot of hospital medicine. I did a lot of IT work in the hospital, education stuff. I was chief quality officer at Geisinger from 2010 through 2015, and as said, now with the health plan, but still do a lot of stuff with our ACO and a lot of, I think, the innovative programs, a lot of which apply telehealth, telemedicine in what we do. So I do probably sit in the middle. Geisinger Health Plan is a 600,000 member health plan in Pennsylvania. We do Medicaid statewide. We have 100,000 people in Medicare Advantage. Most of them are in north central and central Pennsylvania, so kind of this region and a little bit to the west of here. And then the rest is in commercial, and that's about 60% self-insured and about 40% non-self-insured. And there's just a small 20, 30,000 in the ACA. So we do a little bit of everything. And the size of the plan, we don't really specialize. So, like, we don't have a Medicare person and I'm the chief medical officer and do a little bit of everything. And I'm really excited to be here and talk about this. Hopefully we can get into a conversation, because I think, I'll just say to start, my view, a lot of the back and forth, I think, between plans and providers around telehealth is the disease is fee-for-service, because actually Geisinger, we've used telehealth a lot, is where you have this care and coverage relationship and you're already paid, and you're just trying to figure out what's the best way to take care of the patient. And many times telehealth's the best way to do it. I mean, I can sit here and list really quickly. I think where we get into this back and forth a lot is because we all live in fee-for-service, just reality. I mean, I'm not Pollyanna to think that doesn't exist. And then, okay, well, how do you pay for that? And should it be different payment from a bricks and mortar to, I mean, it's really a site of service discussion you get into, like we get into everything else, whether it's home infusion of drugs or, should there be hospital outpatient charges for a clinic that is a hospital outpatient clinic that really looks the same as a clinic that's in the middle of a small town. So, I think if we could get to the point we could get past the payment side of it, I think it's really easy for us to have really cool, innovative discussions about where does it make sense to do telehealth and where is it better for the patient. So hopefully we talk a little bit about both of those today, but it's just exciting to be here, and thanks for having me.
Good, thank you.
I can't
Dr.
introduce Kelly
Wheeler.
'cause I don't know anything about her.
You're my disgust.
Yeah. So I have a fairly similar background to Dr. Belger. Chris Wheelock, I'm a family physician. I worked with a family medicine residency as a faculty member for a number of years, did full spectrum family medicine, obstetrics, inpatient pediatrics, and hospital medicine, and then transitioned into a network quality director role. And then was a CMO for a medical group out in Washington State, Peace Health, and was in that role during COVID. So played a fairly significant role in developing some of our capabilities virtually during that time frame. And then this current role that I'm in with Highmark, I've been in for about 2.5 years, and it's sort of forced me to take multiple lenses. So I'm working with the clinical systems in terms of integrating and helping them sort of move more towards value-based, outcomes-based care, and at the same time, like working for a payer for the first time instead of understanding their lens. And I think the one comment I would make is, as you're thinking about a payer system, their lens around telehealth is really about a couple things. One, it's about access, right? So it's a way of expanding access, in particular in areas like behavioral health. Two, it's a customer demand, and what I mean by a customer demand is both, as John alluded to, in the commercial space, there's a lot of self-insured clients, and they are asking, hey, I need something to better manage this chronic disease. So give me like a virtual diabetic thing that I can manage this patient population better with. And then there's actual patient demand as well. Like they want certain things, better, easier access. And then the last part of it from the payer perspective is utilization. If you can develop a telehealth solution that's going to help me control utilization and keep people out of the ER, that's a win for the payer, right? So that's the payer lens for a lot of the telehealth stuff. So I think it's helpful to kind of keep that in the back of your mind as you're thinking about how to approach and cooperate or collaborate with a payer.
And I don't want to jump ahead, but it was interesting you bring up the term access and utilization. And I think from, again, a lot of us on the provider side, while we're completely supportive of telehealth, the idea of access, well, telehealth may add access. By adding access, do you add to utilization? You make access finally easier. Now people get to utilize services that, not that they didn't want or that they didn't need, but they didn't have access to.
Right. And I think that is a concern. And again, that gets back to the payment comment, right? So are we now paying for stuff that at full price that's really not a full price service? And I think that definitely is a concern. So it's that balance of access, the right access, right? So you want to do impactful visits that will improve outcomes and reduce utilization, and not just a bunch of visits for the sake of doing visits. And I think that is part of the concern, both by regulators and payers. Are you just going to add a whole bunch of volume of stuff that really doesn't add value?
Yeah, I think, and I just add, I think it's the right access is what you talk about, because the right access actually decreases utilization from a total cost of care standpoint. So if you have better behavioral health access, there's really good evidence that decreases medical utilization, because someone who has a behavioral health diagnosis and has heart failure, if they're not getting the behavioral health diagnosis taken care of, they're in the emergency room more for their heart failure. And an emergency room visit's a lot more expensive than than a behavioral health telehealth visit to moderate, you can get that cascade. I do think too, that from a payer lens, and whether it's real, I think it's real in some instances, there is a fraud, waste, and abuse concern because, and I think that it probably, that concern is very real, and it's very real in a lot of places within healthcare. But it also ends up taking a lot of the air out of the room when you're talking about telehealth, because you want to make sure that you aren't just churning access, or that a telehealth visit, you end up with a telehealth visit that ends up with a urgent care visit that ends up with a ER visit. If the telehealth visit mitigates so you don't have the urgent care visit and the ER visit, that's the kind of win. But I think on the payer side, you worry that there is this worry, and then it probably, I'd say maybe gets overblown, that you end up with this churn, and the telehealth just is it's a plus one instead of this really a piece of the total care that you're providing for a patient or population.
So from a payer perspective, the behavioral health side of things, what would it look like good access to you, and what kinds of things do you want that good access to address?
Yeah, I'll answer that first. So I think from the Highmark perspective, we're looking at it fairly holistically. And I should have said Highmark is a Blue Cross insurer. So similar to what Dr. Belcher said, we have Medicaid, Medicare Advantage, and commercial, and in 4 states, New York, Pennsylvania, West Virginia, and Delaware. So I think to us, behavioral health is all behavioral health. So some of that could be health coaching, some of that could be counseling, some of that could be med management, diagnosis with psychiatrists. And again, I think we, in some areas we'll look at utilization as being bad. So like if there's a specialist to PCP ratio, that you kind of look at, and if on average a patient sees their PCP twice a year and sees 10 specialist visits, we as a payer would perceive that as bad, right? We'd want them to see the PCPs more and the specialists less. But for behavioral health, like all of our goals are unlimited. More behavioral health is better. It's sort of the lens. And again, we recognize that different people are going to have different behavioral health needs. Not everyone necessarily needs to see a psychiatrist. And we also recognize that behavioral health, there is like sort of a frequency of visit thing. Like you can't go to a counselor once and magically fix everything. So there is that recognition that there has to be a series of visits in order to get value from the visit.
Just how big's Highmark? How many covered lives, just from a?
Oh, so that's a great question in total, because it's always shifting.
Ballpark.
Yeah, it's probably like 9 million or so.
Yeah, I just was trying to, Geisinger Health Plan has 600,000, Highmark has 9 million, so there's a big scale difference, and which is a good thing. I mean, Highmark's is the main Blues plan in most of Pennsylvania, West Virginia, New York, and Delaware.
Correct.
Yeah, see. And I would agree with that exactly. I mean, I think in behavioral health, especially from a counseling standpoint, there really isn't a ceiling. Now, what I will say is there's a lot of products out there from a telehealth standpoint in behavioral health, and what we look at when we're evaluating them is engagement and outcomes. So many of them will come to a health plan and say, well, we want to work with you and pay a PMPM. The health plan would pay a PMPM rate to get that telehealth behavioral health provider as someone we work with actively, not just part of the network, but someone we're looking at. What I look at is, one, I want to know what their engagement rate is. So, they engage a patient once, but what's the follow through, and does that patient engage with whatever it happens to be? It's an app. It's an app with counselors behind it. It's take your pick, because there's all kinds of things out there. And I think it's great that there's people trying this because behavioral health there's just a dearth of access to care. There's not counselors, there's certainly not psychiatrists. There's not psychologists, and there's not counselors. So, anybody we can get in network for behavioral health to provide the care is, we'll take you in a heartbeat.
Assume even the urgent care, ER avoidance kind of thing would be a big deal.
I think that's part of it. I think the other part of it is, and again, if you look at people with chronic medical diseases that have a behavioral health diagnosis, it's somewhere like 3 to 5 times, depending on the line of, how old they are, line of business, the cost. So you take a heart failure patient without a behavioral health diagnosis and a heart failure patient with a behavioral health diagnosis, the one with is going to have 3 to 5 times the cost over a year. So if you look at total cost of care, PMPM, PMPY, per month, per member per year, it's a big difference, and that's because they don't have, they're not taking their heart failure medicines because they're depressed, and you need to treat the depression. I mean, it's an aside, but this notion of carving out, Pennsylvania does that in Medicaid, carving out behavioral health is just, it doesn't make any sense. I was going to say it was crazy, but that's a little bit, people's physical health and behavioral health are really one and the same, and you need to do that together. So, I mean, I agree completely. If you want to provide behavioral health by telemedicine, I'm all for that. Now, again, the payment standpoint, if we're going to pay a PMPM for it, which means we're paying up front, then we want to, I want to know, is it going to help? I don't want to just throw that PMPM to something that isn't going to add value.
Yeah, I would agree with that. I think just to close out on what he said, I think we don't really cap visits, volume, but we do put a quality lens on it. Like, are you providing good quality behavioral health that's evidence-based? Are you driving, outcomes? Do you have continuity with a patient? Those are the kind of things that a payer is looking for from a behavioral health standpoint.
I just want to ask from the payer perspective, is there any exploration of telehealth as pertains to like transition of care, or maybe even visits such as diabetes classes or nutrition counseling? Because those are things that we struggle with in the trenches. Patients not showing up for different visits, where they might be more inclined to do it from the home because we know behavioral health has been extremely valuable. We're coming down the notion. So transitions of care and group visits, that was really my question.
Could you maybe repeat that just a little? Make sure.
Yeah, so the question was about telehealth for things like transitions of care, group visits, diabetes group visits. So we've done some of that. I think we've done much more of that within a, not really capitated, but within a care and coverage environment, so that it's not paying for it as an as-done basis. But so, for example, we have our Geisinger has its own Geisinger at Home, which is for generally the sick elderly, but it's not. There's other people where we're providing a lot of care in the home. And there's a lot of transitions of care with that. And we use telehealth a lot of times, sometimes directly, sometimes we actually have a community health assistant in the home with the patient, and then they're telehealthing to a central person where there's a physician or a nurse practitioner or somewhere else. So we do a lot of transitions of care with telehealth. But many times we're not paying for that on a fee-for-service basis. There's some other arrangement, mainly because that transition of care, if you succeed at the transition and they don't get readmitted, there's clearly a lot of savings to the system. We have done some diabetic group visits through that. Again, it's usually within some more global arrangement. Maybe there's a PMPM or a capitation to take care of diabetes, and then we're fostering telehealth to use as a modality in that. We haven't paid. I'm not aware that we have anybody that we're paying a fee for service to do a diabetic group visit, for example. But that's not to say we wouldn't think about that, but that would be, we aren't doing it from a standard situation.
Yeah, so speaking to those two topics, so I think the transition of care topic in particular is one where collaboration could be really helpful. So we're exploring with a couple different clinical systems the option, like you've got a community health worker that's going into the home, or someone that's already in the home, they bring a tablet with them, and then they do that transition of care visit remotely. We have one partner that has like a virtual center, and when they can't get the patient a follow-up or they don't have a PCP, you know, they'll do a virtual visit with the patient. So I think that's an area, if you're doing that, that's a good space to kind of work with payers around getting, because I think, again, payers value those transition of care. There's pretty decent evidence that folks who get transition visits don't end up back in the hospital as often. So, and then around the group visit piece, ironically, I actually started and ran diabetic group visits for 10 years. So it's a soft spot for me personally. We don't do, so what we do have is we have vendors, you know, that do chronic disease management, you know, through like a tablet or phone platform. What a number of those vendors do is they will work individually with a patient, and then they sort of graduate them and say, okay, you know, you've met your goals, you're on a good trajectory, self-management wise, and then the vendor will then offer them, hey, we also have these group facilitated things, so you can transition into that, and if things get worse, you can always transition back to individual. So that's really about all we do in the.
That's outside of the PCP, then, as a separate vendor.
Correct, yeah.
Gotcha.
Yeah, go ahead.
And sorry to make you back up. The question on engagement, you said focus on engagement and outcomes. So how do you measure engagement or engagement rate? Because I might be looking at it.
Yeah, it's a great question. So the question was, how do we measure engagement? A couple ways. So one, I'm interested, and one of the first questions I ask a vendor is what's your follow-through engagement rate? So, you know, obviously because in the way this usually works with telehealth or one of the, a disease management is, you know, we give them a list and say, here's the patients that are in whatever, heart failure or diabetes, whatever the bucket is, and then they attempt to engage them. So first we want to know how many do they actually engage up front, because obviously a lot of people say no, and I think there is better engagement. I was just on a meeting yesterday. We were trying to categorize the no's because we had some internal programs, and we were looking with the hard nose and versus soft nose. And the hard nose, we were talking about working with a partner, a vendor, to say, you know, can you maybe help us engage these hard nose? And it was in diabetes. So I'm interested in how many people they engage up front, and then you know, how many people at 3, 6 a year are still using the tool. The number I'm looking for is different depending on the tool, just because there's different diseases and the engagement rate. But because you talk to some vendors or tools, and you find that 6 months later, almost no one's using it. And then just there's a reality. I mean, there's a lot of work being done on behavioral economics, and if we could just harness what Facebook and Amazon and you know, we do some of that in healthcare, but we aren't anywhere close in healthcare to where they are being able to influence, nudge, you know, using behavioral economics tools for people. But so that's what I'm looking for in engagement. And then outcomes, we try to track, and you know, the best way to track, we got in a lot of trouble with doing before and after, because when you do before and after tracking, you get a lot of regression to the mean, and so we really started to do propensity matching tracking of people, and to say, well, has it changed the outcome? So if this is for behavioral health, is the population you're doing this on, in a propensity matching standpoint, are there survey scores better? Are they in the emergency room less? Are they in the hospital less? If it's, those type. So we're really looking at outcomes, and most of the time, total cost of care outcomes, because there's nothing, I think, there's very few diseases, I mean, some specific ones, but very few now that are what we're spending our money on in healthcare that are single diseases. So, the diabetes, there's all kinds of other things going on with them. As I said, behavioral health plays a role in everything. So we're looking at total cost of care outcomes for whatever the population is.
So I want to make sure that we progress through this, but I also, honestly, this may be as valuable as anything to get you to have an opportunity to speak to a payer. I can't overemphasize that. So, but let me ask you, maybe going to your point where you said, I think you have an idea of something you want to do, but it may not fit in what is published as, well, we pay for this. Do you guys mind? How would somebody like her approach the payer that she wants to reach and go, we have an idea. Can we do this? Or could we put a pilot together? What can we do to move from what we're allowed to do today to maybe what we should be doing in the future?
Yeah, I guess I can take that first. So at least I can speak from the Highmark standpoint. I assume this is true for most payers. You have some interface to the payer, whether it's like an account liaison that does contracting. We have a bunch of field-facing folks that do like the VBR programs. I work every day with clinical systems, so that's my main role. So Highmark recognized there's value in that and created this role. This role didn't exist before I took it. So again, it probably depends on the payer, but generally approach whoever you are currently interfacing with and sort of share that idea with them, and then they should be able to tell you who the right person from that payer is. And again, as long as you think about it, try to put the payer lens in place and like what's in it for them. I think that's sort of the way you want to go at it. And as we've said already, it's really total cost of care management, utilization management, access kind of stuff that matters.
And I will add to that, when I see it from Highmark and Geisinger's perspective, I'm from the Right Center, so we meet monthly. Dr. Bolton,
Okay.
you're on a lot of the calls.
Yeah, I do.
I'm sure your relations with and contacts with Right Center more than that even. So it's also on the health centers too to build those relationships, because it's relationship based. So I think we're all thinking for us.
We had a couple polling questions. I don't know whether we've gone past this or not, but let's give it a shot. We were just going to do a response with a show of hands. How many people work for an academic medical center? Urban hospital or clinic? A rural healthcare facility? A private practice? A telehealth or a tech solutions company? Okay, managed care or health insurance company on the payer side? Okay, we're going to skip other.
It's funny that private practice was so underrepresented, but that's the national trend, right? The private practices are slowly disappearing, so it's funny to see that in the room.
Let's go, how long have you been in the telehealth space? Less than 2 years. Okay, nice, good. 2 to 5? 6 to 10? 11 to 15? Over 16? Jeez, there's not many of us. Actually, we'll skip this one. So we'll jump, and guys, I do not want to bypass the questions. If you got a question, bring it up. Again, for many of us, we don't have the opportunity to speak to these guys directly. So please take the opportunity to do that today. And again, I'm from Kentucky, University of Kentucky. Every year we do a telehealth summit, kind of comparable to this, and Matrix is very involved in our annual summit. And I think our tagline for this year's summit is going to be telehealth ... is just healthcare. Again, I remember 30 years ago, when we first started talking to Medicaid and commercial health plans, the idea that we were going to ask you to pay for us seeing a patient through some kind of a video screen was nuts. Some of them just threw us out of the office, but certainly most of them thought it was just a crazy idea. And so I understand back at that time, we had to put restrictions on telehealth. We just had to be careful because it was such a new idea. But over the last 30 years, and especially the exponential growth through COVID, I think we've proven there is value to telehealth. There are still things in telehealth we probably shouldn't do. We need to hone in on that. But are we moving to a place where telehealth is just healthcare, and every time you as a provider see a patient, whether it's telehealth or not, you put your license on the line, as do all of you that are providers? And so should we move to a model where telehealth, as a provider, you make a decision, is telehealth appropriate here or not? If it is not, don't do it. And ask that patient that I need to see you in person. So my hope is that we move to a place where the systems that control our providers and dictate what they should or should not do work without having to overlay new restrictions on top of it. And I'd like to hear from you guys the idea of, the balance between allow the providers to make these decisions, or are there certain restrictions we need?
Sure. I think foreshadowed this in the beginning. I think I like your tagline, it's just health, because I think telehealth is healthcare. I said, I'm the chair of Pennsylvania's Board of Osteopathic Medicine, and, that's the place where we decide whether you're within the Medical Practice Act and whether you're doing that correctly. It's not but there is a payment. The question really isn't whether it's health or not. Or is it health that we're going to pay for? Because there's lots of things that are bricks and mortar that when you get into a discussion between a payer and a provider that you're not going to pay for, especially on a fee-for-service basis. So I don't think there's anything, though, that being video or being remote or that's, again, within the realm of medical practice that's any different from a telehealth standpoint or not.
Yeah, I would agree with that. I see telehealth as a platform for care delivery. And I think the thing that both the payers and the clinical organizations need to think about is what's the right platform for what. So, you can message stuff through text or a patient portal. You can see the patient in person. You can see them via telephone. You can see them in video. And I think that's the thought process of like what's appropriate for what. And there's a lot of challenge to that, right? Because there's your own sort of sense of what's appropriate for what. There's the patient's sense. Like sometimes the patient's like, well, I don't want to pay for that. Like, why should I have a copay for that? I didn't even see you in person. And then there's physician discomfort. I dealt with a lot of that during COVID. I was talking with our neurologist, for example, and there were certain things like I don't want to deal with a video visit for a movement disorder. I don't feel like I can adequately do that. So I said, well, what about a headache? Is that something that you can? So even from a physician standpoint, there's an evolution about, or not just physicians, but all clinicians, of what they're comfortable with doing virtually versus not. So I think there's that component of it. And then, yes, there probably will ultimately be some regulation, right? The same way there's regulation around advanced imaging. I don't know exactly what that looks like in an ideal world. I think minimizing it is probably the right way, just setting up sort of broad categories, but I don't see a world where there's like no regulation around telehealth.
And I do think, and obviously any regulation, there's unintended consequences of, and I think about where we are, and I don't understand it completely, but where we are in Medicaid with telehealth and, this kind of requirement that which I think Pennsylvania is not enforcing and most states aren't enforcing, but there is a federal requirement that if you're doing telehealth and Medicaid, and maybe it's just for behavioral health, but that it has to be bricks and mortar to bricks and mortar. And, that it all got thrown out the door. Everybody ignored that with the public health emergency, but now that the public health emergency is closed, technically by what's on the books, states in the Medicaid program shouldn't be paying for that. And again, most states are just kind of looking the other way at the moment, but the question, we've had these discussions, well, what happens if all of a sudden they don't? Because both from a payer standpoint and a provider standpoint, there's just a lot of care getting provided. And we already talked about the access issues in behavioral health. So, and probably when that came about, it was well intended because of where telehealth was at the time. I mean, I think, we did a lot of bricks and mortar and bought all these carts and everything else to be able to do telehealth that way. And of course, now you just pick up your phone and you can do it on the phone. So it will be interesting to see where that goes.
Okay, so theme number 2, the integration of telehealth with traditional healthcare services. You guys.
Yeah, I can start with that one. So in my mind, this gets back to the fragmentation of healthcare. So you have a bunch of things the patients can just do on their own, right? There's stuff that's advertised. There's stuff that the payers are putting into market. We're putting in various behavioral health solutions. We're putting in chronic disease solutions. Highmark has a virtual physical therapy solution. So there's all kinds of things that are out there that are direct to patient. And then how does all that tie together? So like you're a physical therapist, or you're a patient, or you're a PCP seeing someone, or an orthopedist seeing someone. How do you even know that this patient on their own has signed up to do virtual physical therapy in their home? And how does all that information get passed and connected? So I think that's going to be one of the bigger challenges. I think the good news from what I've seen from the vendor space is more and more of the vendors are prioritizing integration. So their platforms now are capable of pushing notes into EMRs, or they also now, many of the vendors offer a platform that you can have your own providers on. So, you have a virtual urgent care platform. If you want your clinicians on that platform rather than then the vendor's medical group, you can directly have your own physicians on it and then document within your own EMR. So I think that's sort of where a lot of this is going, which should make the integration piece a lot easier.
Yeah, and there's lots of evidence that having a good primary care base is better for healthcare. And I think one of the dangers with the proliferation of telehealth is exactly, what you noted, is that you end up with more fragmentation. And I think, a lot of people raise their hands with the academic medical center piece. A lot of this too is training the next generation of physicians and other providers with a different type of coordination. Because the old type of coordination was where they all came to your office and saw you. Now maybe they only do that once a year, but you're coordinating all this other care, and that's just a different skill set. Now I think the future generations will be better at that because they're walking around with a phone in their hand and coordinating all the other stuff they're coordinating. But I think we need to think about how we train healthcare providers across the board, because it's just going to be different. They're going to be able to get access to things from all kinds of different places, and if it's not coordinated, it's probably not going to be helpful.
I'm glad you brought that up because, again, I work at the University of Kentucky Academic Medical Center, and we've had one of our family medicine residency training directors really engaged in this idea that as a physician, I'm accustomed to having 4 residents come to my program every year, and my job is to teach them how to be doctors. And he said, but what I realized over COVID, I have to teach them to be doctors that also use telehealth. And, and, and that surprised me because we're talking about 25, 26, 27-year-old, in my mind, kids that grew up with a smartphone in their hands. This should be second nature to them. But, and I said, you got to give me an example, because when I go talk to people, I can't express this. And he said, okay. And I'm not a clinician, so all I can express is what he told me. But he said, at the end of the clinic day, the resident was telling him of their experience in the day, both patients that came in and patients that he saw in telehealth. And he said, well, I think Mr. Smith may have carpal tunnel problem based on what I talked to him about. And so the residency training director, and again, I don't know what it's called, but you have the patient do this to understand the flexibility and what they can do. And the doctor said, did you have them do that? Because they're on an interactive video call. The patient's on a computer, a tablet, smartphone. And he goes, well, no. And he said, well, what would you have done if that patient had been sitting in front of you in clinic? He said, oh, I would have had him do this. And he said, well, you have a video call. And I think of my kids who are in their 20s and 30s that sometimes they won't call me, sometimes they'll FaceTime me, but then they'll put the phone down to where we can't see each other, but they're using their phone as a smartphone or as a speakerphone. And I think this resident was doing that. So we realized, and that was the most important example he could have given me, we have to now teach them to do this. So, yeah, I appreciate you saying that. And I thought I was like the only person running into this. But yes, it is something that we're going to have to deal with. I'm sorry, somebody had their hand up there and then over here.
So just talking about that coordination of care makes me think about care coordination and how that could be a really difficult thing to get paid for in a lot of situations. And how much, we're talking about decreasing emergency room visits and improving overall health. And that care coordination, helping connect patients to different services and filling out the applications and getting all the way through the process. To me as a clinician, if there was someone to help do that, that wasn't me trying to sneak it in the appointment, would do more than anything else to improve general health outcomes. I know there's talk about community health workers, but I'm wondering if beyond that, if we're going to see make it easier to build for care coordination.
So the care coordination billing is driven by CMS. So that, and insurers generally follow CMS. What I will say that Highmark does is we pay care coordination fees based upon just your membership. So we are paying primary care physicians today, a per member per month kind of care coordination fee where you don't have to demonstrate anything. So we recognize that that's an important thing. We also have, most insurance plans also have their own care coordination on their side. In fact, I think it might even be required on the Medicaid side by a lot of states. So I think, again, the key probably is to integrate it, right? So we have an insurance care coordination. You may have some of your care coordination. How do those two things integrate? With community health workers, how do they fit in that space? How does the inpatient care coordination talk to the outpatient care coordination, talk to the insurance care coordination, talking to the community health worker? I mean, that's the challenge. You've got a lot of people all sort of doing similar functions, and in many cases, they're not always talking to each other.
We had a question over here. No? Okay, yes, please.
Going back to education, do the peers have modules or things like that they could share with health centers as far as the training? Because you have your own telehealth programs, but to his point, there's scenarios that you just have to think out of the box. And I didn't know if that was maybe something that you could share with the health centers.
Yeah, I think it's a good idea. I mean, we don't have anything canned. We do a lot of education, and we have students and residents who end up rotating through and working with us. But we don't have any kind of modules or education. The other thing I would say about that is too, I think, the example you gave, and I don't remember what, one's Tennell's and one's Phelan's son. I don't remember which is which when you're doing the carpal tunnel. One, you tap on the median nerve, and the other ones you do this. But it's a good example of, you need to train people to solve problems, because the things that you memorize and even the medicine that I learned in medical school and in residency, a lot of it doesn't exist anymore. I mean, the example I always use is beta blockers in heart failure. I mean, if I had told a professor that I wanted to use a beta blocker, which is if you're not clinical, is a common thing used for high blood pressure, and if I said I wanted to use that for someone with heart failure, I'd have failed when I trained, because they were thought to suppress the heart. And now, everybody that has heart failure should be in a beta blocker, because people realize that it tamps down the body's response to heart failure, which is actually your body attacks itself and it's worse. So using low-level beta blockers in heart, but it's an example of you're training people to solve problems, and part of the solving problems today is using telemedicine. So that's just one of it's nothing different than a stethoscope. It's a tool in an armamentarium of a clinician to take care of people.
And I would just add to that, if anyone's ever done a home visit, there are always things you can pick up in a home that you could never pick up in the office. Like, you can be seeing patients for years. You can walk into their home and in 5 minutes, okay, now I see why they're falling all the time, because they've got throw rugs everywhere and they've got newspapers stacked 5 feet high in the hallway, or, et cetera. Or you look in their kitchen and you see what they're eating and you're like, okay, no wonder they're diabetic. So I think that's one of the values of telehealth. You essentially get to do a home visit. And when I've done telehealth visits with patients, I will have them walk around their house. If there's specific questions I have, hey, open your refrigerator and show me what's in there. Let's walk down to your bathroom and take a look at how that's set up. You said you slipped getting off the toilet the other day. So I think there's actually added value you can get with telehealth, because you are essentially getting a virtual home visit.
Yeah, and in my example, people, if they hear that example, they always go, okay, well, you got to teach them how to be a telehealth doctor. And I tell them, I said, this was a third-year resident who we actually do, on the first week of residency, we have a 4-hour session that we train the residents, and then we come back in 3 times throughout the year with another hour, in addition to what their training director does every day. So we had kind of prepared them for this, and to hear that resident didn't even think about that. Now, we never said, do a physical manipulative on screen. We kind of assumed that. And for them not to do it was incredibly surprising. So just expect the unexpected, I would say. So this point, I think is important to me as an academic medical center, because there are vendor providers out there, Teladocs, Amwells, lots of different companies that provide an incredible amount of services, give people access that have never had access before, and a lot of the payer communities leverages them, because I know my providers are like, I don't want to be on call 24 hours a day. So I get that, but I'm really interested in this kind of back and forth between community-based providers, who may not always be accessible, and these national programs, and how we should leverage those.
Yeah, I think coordination's came in the answer to the last question. Coordination's really key to this. I mean, from a payer perspective, we do a lot of it ourselves, because we have a care management, huge care management arm, and I know Highmark does as well. And we pay primary care providers care management fees in Medicare and in Medicaid to be able to do it, mainly because we want they're coordinating the care, we want them to have, and we don't want to decide it for them. Now, we do some over the top, so we work with Teladoc, for example, and we started working with Teladoc before the pandemic, and I was real clear as chief medical officer, we have Teladoc, from my standpoint, both for physical and behavioral health, as a safety net. And we used it during the pandemic. We said, you're a Geisinger Health Plan member, you can go to Teladoc. There's no copay. This was during the pandemic. But we really want you to do this with your primary care physician. But if you can't, here's this thing that's there. You go on our website. We gave literature to people.
Good.
You can do this, but and it really is about the coordination, because I do think it is detrimental if you have a whole bunch of people trying to pick off patients. I mean, it's no different than lots of these companies that are trying to you see the ads on TV that are trying to send diabetic supplies to Medicare beneficiaries, and the primary care physician doesn't know they're getting them, or, on and on and on. We can write your prescription through us. You just ask a couple of questions online and you don't need to see that's not any good either. So I think really the coordination's key. And that's why I think it's much easier, the care coordination question. If you're doing care coordination through the primary care physician or with the health plan, that's easy. If you're a provider that's trying to set up something in care coordination that's separate from that, we'll talk to you and we'll listen to you, but the other question, back to the original, we're gonna wanna know how you're gonna coordinate with our network, whatever it happens to be. And we do a lot of that. We work with, we work with people in diabetes. We work with people in CKD and ESRD. We work, all kinds of different disease states that are doing telehealth and care coordination, but we want to know how you're going to coordinate with the primary care physician as part of that.
Great.
What to say again on that tip is that a lot of this care coordination does happen in that behavioral health space.
Yeah.
Because those are the people who are seeing the patient every week, who are really, on the ground and knowing what's going on in that home, in that house. And so, it is the behavioral health providers who are doing a lot of that.
Yeah.
As opposed to the
Yep. The other thing I just add while I'm thinking about it is that from a payer's lens, we have to be careful too, because if we go out and partner with a solution and that solution doesn't interact well with our members and the primary care providers or other providers in our network, it ends up them coming back to us and saying, what are you doing? You're practicing medicine and you're taking my business, or you can think of all the things. So from a payer standpoint, our network and our members are who we're working with, who we're working for. And, anything that gets in between that, we especially in our case, we use a lot of partners to do that, but how they interact with our members and how they interact with our network is a huge piece of whether we're going to continue working with them.
Yeah, I would say the lens has to be both how it interacts with the patient and how it interacts with the clinical system. And sometimes one's good and the other's not so good. It's rare to fully see both at like optimal levels. And I think holistically, the answer to this question is there's probably going to be a hybrid, right? And it's probably going to vary based upon where you live, right? Like if you're in an area that's really well supported, there's probably not a lot of need for outside support. But if you're like 4 hours from the nearest cardiologist, having some, vendor type relationship where you can, or a clinical system relationship where that cardiologist can see someone virtually, obviously is a need. And I would say in general, we would prefer to have that need met by the clinical system. So like if you have a primary care practice that's 4 hours away from a specialty area and you set up a room in your practice that allows virtual appointments with specialists, like we're going to pay for that, and we'd probably prefer that, than us bringing in some outside vendor because we know that care is going to be more integrated.
That's helpful. Thank you. we've already done a bit of this, but do you want to touch on the value of telehealth for targeted populations?
Yeah, so I think we have really hit on this. So I think, behavioral health, obviously, we beat up totally. I think there's, the telehealth for like second opinions or for, a specialist, that might sort of a really super specialist kind of scenario where you have like a rare cancer where there might not be a local resource. I think telehealth obviously is widely used for chronic disease management purposes, and some of that is providing direct care, and some of that is providing what I would describe as self-management education kind of tools for patients. So I think those are sort of the big areas where I see, a specific, targeted opportunity.
Yeah, I'd agree with that. I think this follow-up of specialty visits is especially important, but in rural areas, because you may need to see, you have rheumatoid arthritis, having a visit with the rheumatologist to make the diagnosis, but most of the follow-up can be done, and in that case, there's usually medication monitoring and other things. All that can be done with telemedicine visits. I think there's some interesting things. Cardiac rehab, for example, there's actually more and more evidence coming out that the telemedicine cardiac rehab is better actually than the bricks and mortar telehealth rehab, and we've been working in telehealth with that for a while, and on our clinical side, we've closed our bricks and mortar cardiac rehab and favored telehealth. And actually, my wife's had valve surgery, and so she did it, and it was just amazing, and how it was done. I think surgical follow-ups are another thing. You have surgery. It used to be to bring someone back in like a week later and look at the wound and everything else. We can do all that stuff by telemedicine. So I think, and finding those niches where it's better for the patient, and then it's better for the community because you've created access for another patient by doing that. And in most communities, there's a heck of a lot more need than there is actually access. I mean, there are places out there where there's a glut of a particular specialty, but there's not a lot. I mean, behavioral health gets talked about, and rightly so, that there's this huge issue, but there's a lot of specialties where there's a huge issue. Derm's another example. You could do lots of telederm and even just take a quick look at something and get the diagnosis and move forward, as opposed to waiting for weeks to get in with the dermatologist.
I'll just throw something out, not necessarily related to the payer community, from the provider community. One of the really creative things that we have done with this is, again, I'm at University of Kentucky. We have pediatric cardiology program. We have some pretty good guys there. But one of the best programs in the world is 70 miles north of us at Cincinnati Children's Hospital. And our team has had a relationship with them for years and years and years. And we knew that they sent patients up there that had come to UK. And the University of Kentucky said, we want to have a joint program with Cincinnati Children's Hospital. We don't want our patients to physically, it's tough enough for them to come to Lexington, much less another 70, 80 miles. And again, battle the kind of traffic that you do in a city like Cincinnati. And so, and I wish I could take credit for it, but this was all on them, but they had the ideas of, we're going to create a joint pediatric cardiology program with Cincinnati Children. Their providers are jointly credentialed at our facility. They sit in on live surgical procedures almost every day. They sit in on our cath lab procedures almost every day. And we have elevated the level of our program. And originally, they were all coming down to do this, amazingly, taking time out of their productive days. But telehealth has now allowed them to be in our operating room, be in our cath lab, allows our patients to see them through telehealth without having to make that physical trip up to Cincinnati. And again, we have a remarkable joint program right now. So again, from an academic medical center, some people may have said, yeah, but you're the Research One University. Why do you need that? And it was fortunate on our side that our pediatric cardiology program said, yeah, we need them. And it actually helped us recruit a surgeon that we never could have recruited without being able to give them a joint appointment at Cincinnati Children's. So this offers opportunity for some really incredible things that if you have the right people thinking about it, you can do those. We talked about this a little bit earlier, but how can we as the provider industry help the payers? We have from a telehealth perspective, I think have a much better relationship than we did, and again, 20 or 30 years ago. We're all trying to do the same thing. So we've touched on this a little bit. I don't know if there's anything else.
Yeah, I don't know there's a lot to add here unless there's specific questions, but I think, just the lens of, hey, how does it help the patient? How does it help you kind of, again, provide better care, create more access within your system by, again, freeing up space? And then how does it help, the payers in terms of better outcomes, lower total cost of care? And if you can answer yes to all three of those things, then that's that's a project that's worth bringing forward.
Didn't think? Okay. Guys, we have like 7 minutes, so and we have other things that we can touch on here, but if you have questions, please bring them up, because I think that is the more valuable thing that we can do today.
So, Pennsylvania or PA Navigate, I don't know if you guys are familiar with that yet. It was announced, I think, in February, with Line Health, care coordination efforts. Have you guys noticed an impact, or that impacted your organizations?
Yeah, I mean, I know enough about it. I don't know that much about it, but, and I don't think we've seen an impact yet, but that doesn't, I think over time it's going to. And I think, those type of programs where there's a state program where you're trying to bring people, because it gets back to the coordination piece we were talking about. I think it's a step in the right direction as well.
Yes.
I was curious about, we heard yesterday, right, the time that patients stay with one insurance plan is fairly short. Sometimes it's 3, 4 years, 5 years. I'm originally from Germany, the German system is you kind of join health insurance, of which there's 30 or 50 kind of at a young age, and then you basically stay for the rest of your life into old age. And again, in the US, we have the system switching over to Medicare. Now I heard you cover a lot of different insurance segments in terms of Medicaid and Medicare, but to what extent is it hard to justify kind of the preventive investments and paying for those, because the incentives are not necessarily aligned, because you're sure that you still have this patient at age 70, so the investments you're making at age 50 will help you to reduce utilization now.
Yeah. I think it's more of a global issue in the United States probably than it's a local issue. I think, I think it's you have a fair amount of stickiness of your members that are the commercial members, and then they become Medicare Advantage members. I think
That's certainly the hope.
yeah, and I think we do too. Our average length, certainly in the Medicare Advantage space, is 10 plus years. But we have a lot of people who were commercial members, and again, that's a kind of maybe a little bit of a difference with the regional plan. So I could say I'm altruistic when I'm thinking about, but it's also from a economic standpoint, they tend to stick with us longer. But I do think that those questions are concerns when you have people churning through. Probably the biggest example we have of churn is in the ACA space, because about a third of those people turn over every year. And if you look 3 years down the road, it's like 20% of the people that you had 3 years ago, and they're churning in and out of that program too. So they're, that program's meant to be kind of between Medicaid and commercial insurance. So, and you'd make different decisions with all kinds of things about what you're going to do in prevention. You make different, a lot of the issues right now with the diabetic, the GLP-1s, is around the cost. And you might be able to justify that if you knew you were going to have that member for 20 years. But you definitely can't justify it if you're going to have the member for 3 years. And there's lots of people who looked at that economic. So I do think it is a reality, but, it's the system we have, for better or worse. And the German system's actually pretty interesting. So because it is health, and they do have they have insurance, private payers, but. Correct, but it's, that's right. So you end up being long-term with that payer, which changes the dynamic.
And then there's a cap in the insurance, which is progressive based on the income.
Yeah. Yep.
Yeah, I would just say the incentive issue or incentive malalignment goes well beyond telehealth as well, right? Obviously, to do the right thing, it might negatively impact your revenue in the short term, right? Like if you're going to keep people out of the ER that don't really need to be there, that impacts negatively your ER revenue. So that's one of the bigger, I think, issues of our healthcare system as a whole is not having good incentive alignment.
Every system is perfectly designed to get the results it gets.
That it gets. Yeah.
Yes. We have about a minute left. I'm sorry. Yeah, no, please.
So I want to mention it briefly, parity, something very relevant for Pennsylvania. When I think you both primary care, you put your primary care hats on, and you're seeing patients every 12 minutes. You're churning through clinic all day long. And you're doing that via telehealth. Your decision-making is essentially the same. In some cases, probably more complex. And certainly the risk that goes with that can be as well. But we spend a lot of time talking about telehealth, but in a broader lens, when we're trying to get patients to access the right level of care. Is that telehealth program where you're offering on a PM basis because you know it adds value? How does that meld into, fast forward 3, 4, 5 years, a resurgence of that primary care, like, hey, let's drive this as the primary care, as the access to avoid all of that specialty access, all of those specialty consults that are in fact adding all the costs to the system, or a lot of the costs to the system. So not necessarily a direct question, but just, we said parity once, and that's a huge part of the equation.
I do think one reason why we have that kind of churn in the primary care physicians are seeing patients every 12 minutes, I think, is fee for service, because that's the way you get paid, or they get paid. And I think which is one reason I believe changing the system, if we could change the payment system, it would help, because then you get into the primary care physician saying who needs to be seen for what, and how do we coordinate that care, as opposed to, gee, the only way I can keep the lights on and pay the staff and raise a family is to see patients every 12 minutes. So I'm not, I think, and telemedicine's a piece of that, because that's a piece of the coordination. Does everybody need to come in to be seen? Again, everybody comes in to be seen because that's the way you get paid. So I think a lot of what's driving the way the system is the payment. And if we're able to work through the payment, then you actually get innovative minds thinking about how do we provide better care for people in communities, as opposed to how do we get paid.
Yeah, because I think you can do a lot of there's a lot of data too that the more touches, the better people do in chronic disease. So your ability to do like a 5-minute quick interface, and it doesn't even need to be you. It could be a pharmacist, a nurse, et cetera. Like all of that, the mechanisms to really pay for that don't really fully exist. So I think that's, again, if the structure of payment were different, it would allow the flexibility and creativity to do some of these things.
And just a one sentence follow-up, as for Pennsylvania, non-parity would in fact create a perverse incentive when we talk about behavioral economics.
Mm-hmm.
You don't want to push that lower cost of care access.
Right.
You're in fact incentivizing people to come in.
Right. Yeah, and so in Delaware, for example, jumps to mind, which is one of the states we insure in. Delaware does have a parity law, and again, we we're supportive of that as a payer and don't have any problem paying parity for telehealth.
All right, I got to get you guys out on time. Maybe you could ask the question afterward. Please thank Dr. Bolger and Dr. Wheelock for doing this. It was very kind.